Hello, today we're going to talk about current developments in ED operations. My name is Brian Yoon. I am the Vice Chair of Clinical Affairs in the Department of Emergency Medicine at Boston Medical Center. I'm also an Associate Professor at Boston University School of Medicine, and I have no financial disclosures. Today we're going to tackle three objectives. The first, we're going to illustrate a different way of framing process improvement efforts in relation to expected level of adherence. Second, we're going to examine equity and staff wellness in clinical operations. Third, we're going to identify developing alternative pathways to admission. In terms of process improvements, we all have limited time in terms of our ability to get things done. Certainly, we all feel overstretched at times, maybe some of us all the time. And certainly we have a number of priorities. And in this way, I'd like to show you a model where we can think of what we're trying to achieve and what are the resources that we have to achieve those things. And the two things that you need to keep in mind is what is your expected level of adherence and what is the expected level of effort. In terms of adherence, what we're talking about specifically is our own staff. And when we're asking our clinicians, our physicians, our APPs to do something, what outcome are we trying to achieve? And in that outcome, first, you need to understand, is it measurable versus non-measurable? And importantly, is a third party looking to review those outcomes? And the other component to adherence is the risk of non-adherence. If a specific process is not followed, will there be patient harm? And then in terms of effort, it is based on what you have available for your own resources. And based on that, it is whether you prioritize it, whether your department prioritizes it, or whether your hospital prioritizes it. And for those institutions where there are frequent rotators, such as off-service residents, it's going to require even more effort and more frequent effort in order to achieve an expected level of adherence. I'd like to show it on a graph, which hopefully will make things clearer. This right here is the ideal effort to adherence graph. You put in, as the clinical operations or operations leader, a given effort, and your hope is that it achieves 100% adherence. But as we all know, the effort adherence graph looks probably closer to this type of figure. And as you can see, as we put more and more effort, there is likely going to be more adherence, but at diminishing returns. And so the question you always need to ask yourself is, how do I get close to this type of graph? And some of the interventions or strategies that we think about are anytime you are doing process improvements, think about how can you get at specific decision points in a patient's stay for physicians to do the right thing. And that is where default choice comes in to play. If you pre-select certain decisions, then you're more likely for the desired outcome to come true. You can also design processes that adhere to social or business norms. Social norms are very powerful tools, and if folks see other people behaving the appropriate way, it leads them often to also act in that appropriate way. And I'd just like to give you an example. At a hospital, they had issues ordering the correct precautions for patients, often leading to rework. So a patient who was at risk for C. diff, a physician would order stool studies, including C. diff, and oftentimes would forget to order the precautions. And if the patient needed to be admitted, they would get a bed, only to lose the bed because the correct precautions were not chosen from the beginning. And the initial strategy was to educate, but unfortunately, there continued to be safety reports in near misses and patients going to floors without the correct precautions. And this is where default choice and social norms came into play. And so what ended up happening was the team decided to adjust the order for the C. diff so that the precautions were linked with that order. And in this way, instead of a two-step process of ordering the test and then ordering the isolation, they were grouped together so that when a C. diff test was ordered, the automatic correct isolation would also be linked to that order, avoiding any mistakes from occurring. The next topic that I just want for it to be on your radar is the importance of equity and wellness. These are two separate topics, but we're going to cover it in one slide. And really, it's, as we have known with COVID, our team have taken quite a hit, and in between surges, there is little to no opportunity for recovery. And this is where, as we implement processes, it is extremely important in understanding where your staff is in terms of their baseline. And so I encourage you to survey your staff to get that baseline. Where are they? How's burnout? What are the areas of pain? What are the thorns on everyone's side? And start addressing these by creating a staff wellness committee. And importantly, make sure that this staff wellness committee is multidisciplinary and helps to start tackle these paper cuts, these thorns that get in the way. Because at the end of the day, when people arrive to work, you want an environment that is conducive to wellness and productivity. Another tactic that can help address staff wellness, especially for physicians and APPs, are encouraging breaks and eating on shift. Of course, not where there are areas of patient care, but in the cafeteria or the break room. And this can be accomplished by swing shifts. And these swing shifts can be coordinated throughout your department to allow people to get 15 minutes, 20 minutes to take a break. The other thing that's important is to incorporate patient equity into your clinical processes. And the way to do this could be everything from tapping into your department's or your hospital's patient and family advisory council. This is usually made up of former patients or family members who can provide insight into a patient's thought process. And certainly getting their opinions can be helpful in making sure a particular process is equitable. If your department has a director of equity or vice chair of equity, it's also very valuable and important to incorporate their thoughts and ask them questions and help broaden the team outside the traditional operations team members. Certainly a number of hospitals have started screening for social determinants of health and strategizing certain intervention efforts. One of these potential efforts are through the use of an ED navigator who not only helps screen social determinants of health, but then can help the patient navigate outpatient resources. An example here is there may be food insecurity that a patient in your emergency department may have, and through this ED navigator, they can direct that patient to food banks or certain programs to help. The last thing that we're going to talk about are alternative pathways to admissions. Certainly the choice dichotomy that emergency physicians and APPs have are often to either admit a patient or discharge. With the advent of observation units, a third pathway appeared. But now there is a fourth pathway, and this is alternative pathways to admitting a patient within the four traditional walls of your own hospital. And in escalating format, we'll talk about virtual observation unit with community paramedicine, home hospital, and interfacility level loading if your hospital is within a healthcare system. The first uses a blend of mobile integrated health, community paramedics, and a virtual platform. And the process is a patient comes to your emergency department, they're seen by you, and you realize that they would benefit from perhaps another day of observation. Instead of hospitalizing them in your hospital, they may be a good candidate to go home with a community paramedic visit that day or the next day, and a telehealth visit via the patient and an emergency physician, all helped by and through the community paramedic. This allows you and the hospital to preserve hospital beds for patients who are sicker, and also allows the patient to be in the comfort of their own home and continue receiving treatment and ongoing monitoring. The next step in increasing level of acuity is home hospital. And the home hospital program is really a team-based effort with a home hospital team, traditionally hospitalists or family medicine physicians, and an emergency medicine physician. An emergency medicine physician will see the patient in the emergency department and determine that the patient needs hospitalization. And that patient may actually still benefit from additional monitoring, but it can be done in the comfort of their own home. In this case, instead of a paramedic, the home hospital team is comprised of a physician, a nurse, and oftentimes an advanced practice provider. A nurse and an advanced practice provider will do a home visit, and a physician is available either through telehealth or phone consultation. And the patients are seen multiple times a day by this home hospital team. The capabilities of this home hospital can be pretty broad, including, in addition to the traditional IV antibiotics and IV diuretics, but also remote patient cardiac monitoring that can be delivered through the home hospital team. And finally, it's interfacility level loading if your hospital is within a healthcare system. The traditional model has been that community hospitals transfer patients to academic medical centers. Oftentimes that was one way. This idea flips it and opens all hospitals to start thinking of themselves as a player within a healthcare system. A patient that is at an academic medical center who needs hospitalization, but perhaps not the tertiary or quaternary skills of that academic medical center, can utilize open capacity in a system and transfer that patient who requires hospitalization to their community hospital partner. Ideally, the healthcare system would share an electronic health record, and that way preserve and allow seamless capacity usage throughout the healthcare system. And patients benefit, importantly, by getting a hospital bed quicker and subsequently their inpatient medical care sooner. Thank you for listening, and these were some high-level topics of clinical operations that are the latest, and I want to thank you for listening and have a great day.